Good evening, ladies and gentlemen. Thank you for a nice introduction and inviting me to speak in International Oncology Hematology Nursing Conference in session of hematology disorder. My topic is what's new in acute myeloid leukemia research. And new is actually geriatric and genomic scale. We will see how to implement these things in the acute myeloid leukemia. So in next 15 minutes, in same context of what is the new in acute myeloid leukemia, I will take you 5 steps. First is eye-opener, and then second is AML challenges in 2022 and their solution, AML journey from toxic to targeted therapies, then real-world experience to understand the basic of geriatric and genomic tool, and finally conclusions of the nursing care, hits of A to G of acute myeloid leukemia, what to remember. And the 5th questions will be the bonus questions. How do you treat AML in 2022 geriatric versus genomic tool? So eye opener, what color is the ribbon for leukemia? So here is evidence-based. Orange color is the AML ribbon. How are oncology classified? Solid organs, medical oncology, stem cell disease, curable and incurable, and lymph node disease is lymphoma. Actually, we are talking about stem cells. And how are stem cells disease are classified? They are based on the number of blast cells. If less than 20%, we call it a chronic leukemia. And if it is more than 20%, we call it acute leukemia. And we will talk today AML, which is the more than 20% blast cell. Now, challenges. What will be the 5-year survival of AML in 2022? AML remains the most daunting challenge. Since the early 1960s, 5-year survival rate of many blood cancer have doubled, tripled, and even quadrupled, but AML is different. You can see where we begin, the dismal survival, but as you can say, survival is improving from somewhere between 40% to 80% based on, again, genomic score and genetics. We will discuss that one. Now, challenge is there historically. When you look backwards, longer you look back, further you look forward, as Mr. William Churchill said in 1944, the Virchow was the first who actually named the disease of the leukemia. And even he said, I don't wish by any means to infer the disease in questions if it is incurable. I hope on the contrary that new remedies will come and that will treat the patient. So this is ongoing. Now we are in 1960 to 70s where the treatment actually started after one surgery of the Virchow. Now, you can say this in Journal 1968, the induction treatment is 3+7 followed by consolidation. So this is about 4 decades ago, the treatment started. Again, challenge is there that AML is clinically and biologically heterogeneous group of malignancies. So challenge there, 2 diseases are not equal. So what we do, AML is complex disease because it has more than 10 major subtypes and other rare mutation. So one size fits all approach to treatment doesn't work in AML. What is the solution? If you go by evaluation wise, you can say pre-target era, we used to check age and performance status, but now we are in era of molecular and genomic, which we'll see today, hitting the right target, not missing any points. So in summary, this is the solution, 1973, first 3+7, then 2 decades, there was no advancement, but over the 1 decade, now we are in era of the targeted era. We have IDH1, IDH2, we have FLT3 inhibitor, and we have other medication as well. We will discuss this. So that's why the standard 3+7 has been beaten by 4 randomized trial based on the Vidaza and venetoclax, low-dose erasine and venetoclax, and then, of course, IDH1 and IDH2 medication as well. We will discuss this one. 4th challenge is some patients with AML are difficult to treatment, which are elderly and frail. You can say even during the diagnosis and early, it is difficult to survive these patients. Survival is lower, and even in relapse, the survival is more difficult. However, now we are in 2022, we have different things in solution. AML without mutation, and you have some treatment, then you have mutation, you hit the target accordingly. And this is like IDH1, IDH2, and FL3. And again, you have to choose targeted therapies versus aggressive chemotherapy depending on the geriatric score, which we will discuss. Now, how to incorporate? So potential standard care of older patient with AML 2022, what we do after making a diagnosis, we start with other venetoclax and then targeted come, we aid it. And if CR, then based on the risk of relapse and performance status, we take accordingly to the patient. Fifth challenge, which is very important to determine the optimal choice, the time. Time is the key here to find these things. And as ideally, same day you should have morphology, bone marrow on your table, and second day you should have cytogenetics, and third day you should have mutation results, FLT3, IDH1, and IDH2. Based on this fourth day, you can start treatment, which honestly was very difficult. However, where there is a will, there is a way. You can use both scores. We will see genetic assessment and genomic score, and you can start the treatment accordingly. So in part 2, we have seen the cancer in older patients. They are divided into 3 groups. Young old, 75 is cut off, middle age is 85, and then older is 85. But how to do this, making the targeted treatment decision, tailor treatment based on the geriatric and genomic tool. So we'll go now part 3, real world experience, basic understanding of geriatric and genomic tool, and incorporate into the real world practice. So this is my real case, which was diagnosed of 1 decade ago, 72-year male who had actually multiple comorbidity, and he was referred to our hospital with a recent CBC, which has mild pancytopenia and peripheral blast cell. And this was the test. WBC count was 50,000 with the blast cell in the peripheral phlegm, low hemoglobin and low platelets, and high creatinine, high LDH, and high uric acid. And the bone marrow was done that confirmed acute myeloid leukemia. So in 2013, how do prognostify the AML? We have just cytogenetics in this patient. I have actually normal cytogenetics, so intermediate risk category. Now the question is how to tailor the therapy based on just for age, performance status, or cytogenetics. Now, if you go in 2013, there are again, the treatment is divided into 0 to 2 performance status and more than 2 performance status. So you have very low options of the treatment. You have chemotherapy and low intensive chemotherapy. It was in 2013. So how the filling the information gap in those days, what is the, so first thing is what we show, what is the risk of the recurrence? How much does chemotherapy decrease the risk? And who is the patient, and what are the risk factors for chemotherapy toxicity, and all the risk factors are modifiable, and what are patient preference. So if you go further, in those days, there is senior adult oncology NCCN guideline 2014, now which is transferred to older adult oncology. What they say, number 1 step is please assess the GCS score. This GCS is different than which we do in our patient. This G stands for geriatric syndrome, C for the comorbidity, and S for socioeconomic issues. So first step is you have to this one, nursing care GCS score. Second step is what is the life expectancy of the patient. You can say dark black, brown, and white color. And this is a good health status. This is the average, and this is poor health status. Like in my patient, it was average health. He may survive like 12 years. And the third step is pre-treatment evaluation. You have to predict the toxicity to cancer treatment. You have to predict the survival, and you have to uncover problem, and you have to improve the mental status and well-being accordingly. So going back to my patient, his functional status 1 to 2, comorbid condition 3+. He has no coagulation problem or nutrition problem or psychological problem. He has a very good supportive system. Now, based on this, what do you think? What is the patient's risk chemotherapy toxicity? It goes from 30, 70, or 100%. Do you think what I told you, can geriatric assessment predict the chemotherapy toxicity? Yes or no? Answer is not clear. So where is the key? Now we are in 2022. There is certain predictive models over there to assess the geriatric. You can say they divide into three things. There are 11 factors. You can say based on the age, performance, standard dose chemotherapy, just hemoglobin, creatinine, and again, all these factors are geriatric score. And based on this, we calculate in my patient, it was about 11 was found. So my patient fall in high intermediate risk category based on this. Now, finally, you have seen my patient. He had reasonable 5 to 10 years survival. He has high risk of serious toxicity. If he recurs, likely to be less than 5 years. Therapy confirms the benefit. You have to discuss balance about the pros and cons with the treatment option. However, it was 2013. I started treatment with ASA with this patient. You can say he took treatment, WBC and blast cell go down, hemoglobin platelets improved. He survived more than 2 years, but eventually he couldn't do it. Now we are in 2022. We have refined geriatric assessment. You have balance tests, you have gait speed test, you have chair stand test, you have mini mental state exam. So this is very important to start the treatment. And the other thing is post-target therapy. You have to see candidates are intensive chemotherapy, then you have to start chemotherapy. And if it's not intensive chemotherapy, you have to check it is actionable mutations over there or not. If it is not, you have to go according to the treatment. Otherwise, you can see B and C, you have actionable mutation, you can treat based on the IDH1 and IDH2 and FLT3 inhibitor. Now, what we conclude in this one, you have two conclusions. One is geriatric tool is useful, but not completely assess the patient risk of severe complication of intensive therapy. It is the time to evaluate the novel and incorporate known parameter, more assessment of the fitness like grip strength, gait speed. There is limitation, lack of availability of the geriatric scoring system, even in NCCN guideline. This is one thing. And what about the after geriatric genomic? Now, target therapies open new treatment avenue for all patients, regardless of age and fitness, for intensive or non-intensive treatment therapy. However, there is limitation. What is the limitation? Optimal choice, and the time is very important because it takes 5 to 3 days. We should have all the thing target on the table, which is very difficult. So this is important thing. Now I will go the fourth part of my talk, which is very important conclusion for nursing care. I made it how to remember, made it very easy. It's hits of A to G of AML. Now A means assess the geriatric score, very important. Know the patient and which treatment approach, risk category, performance status, health profile, and predict the morbidity and mortality as I showed you. B, before beginning the treatment, check do they have targetable mutation, FLT3, IDH1, IDH3. C, check how you can be partnered with the patient to improve the diagnosis and treatment. D, determine and how you can help them maintain quality of the life and confirm the same page with the same goals. E, efficient new treatment are here and changing the treatments over there. And F for feasibility, if you have feasibility of clinical trial, encourage the patient. And G is the getting the guidelines, which I mentioned, NCCN guideline there. And HIT means how I treat the patient of AML. Sorry, this is AML. So depending on this, you can use A to G of the AML for nursing care. Now, high five, fifth part of my talk, which is the last part, bonus question. How do you treat AML in 2022? You will use only geriatric tool, you will use genomic tool, or you use new era gait and grip clinical judgment, or you use both geriatric and genomic tool, and you use all the things together as I mentioned, high five. Now, last 15 minutes in my topic, new in acute myeloid leukemia research. I took you some eye-opener and then some challenges, and I mentioned also solution as well. And real-world experience I mentioned with the case, how to implement the geriatric and genomic tool. And final thing, which is conclusion is important, A to G hits of AML, what to remember for the nursing care, and the bonus questions, which you have seen, how to treat in 2022. And so thank you very much. If you have any question and answer, I'm here happy to all your queries. Thank you very much once again. Thank you.